Thank you so much. Good morning, respected teachers, dear seniors, and my dear fellow residents. So I'm Dr. Neha, second year Dean Resident. My session is moderated by Akanksha ma'am. Today, in brief, we'll talk about the management of hypernatremia. Thank you, Dr. Shalin, for beautifully explaining the case management. The learning objectives of this session today will be overview of basic physiology of sodium and water, various sodium disturbances in the form of hypo and hypernatremia, major emphasis on causes and management of hypernatremic dehydration. So with all the previous knowledge, we know that the water and electrolyte homeostasis is being maintained by the following factors in the preterm babies. As the gestation age improves, the electrolyte and total body water content decreases in case of term babies. With the diuretic phase and increased urine output over next 2 to 3 days, the electrolytes decrease in the preterm babies. Various hormones and their in milieu, like vasopressin, atrial natriuretic peptide, and brain natriuretic peptide, also play a part in managing water and sodium content of the preterm babies. So our body is composed of total body water, which is composing of intracellular fluid, contributing about 30 to 40%, plus extracellular fluid, which is contributing about 20 to 25%. This extracellular fluid is composed of further intravascular fluid plus interstitial fluid. And the other insensible water losses are mainly from the skin and lungs. These insensible water losses are mostly higher in cases of extreme preterm babies because of the exposure to radiant warmers and phototherapy units. This diagram clearly depicts how, with decreased birth weight and gestation, the content of total body water and extracellular fluid is usually higher during the initial phase. But when the gestation and birth weight improves, the total body water with ongoing natriuresis decreases to about 40% in term babies as compared to about 70% in cases of elder babies. Reviewing the basic electrolyte composition, the major part of plasma is being occupied by the major cation as sodium and major anion as chloride, whereas the intracellular composition is mainly by the potassium levels as anions and phosphate is being the dominant anion. So with ongoing different stages of diuretic phase, the preterm babies in initial first 3 to 4 days have pre-diuretic phase, which is due to low GFR and low fractional excretion of sodium. This is probably due to renal vascular resistance, which is higher during the initial phase. But when the ongoing urine output improves, the GFR improves and FENA also increases. Further, during the post-diuretic phase, there may be variable urine output, and after day 2 to day 3, there may be reduced GFR, which further decreases the electrolyte and total body water component. Effect of cord clamping is also being established that the babies, especially the preterm babies, whose cord was clamped delayed as 30 seconds to more than 30 seconds to 1 minute, approximately extra 25 to 30 ml of blood was received in the knee. So this improved the total body water component and maintained the normal hemodynamic transition in the preterm babies. This is also the postnatal physiology. When there is hypoxia into the intrauterine life, the total body water component and electrolyte physiology is different. But during the birth, and especially after vaginal deliveries, when there is increased oxygenation and increased hormonal production, especially the vasopressins after vaginal deliveries, this capillary permeability is again restored and the vascular compartment is being reabsorbed into the interstitial fluid. After brief history of water and sodium physiology, we'll review the sodium homeostasis in the body. Mainly, the sodium and other solutes are being reabsorbed through both the pathways, paracellular and transcellular. From the lumen, most of the times the sodium is being absorbed through the transcellular pathway from the luminal membrane and badly reabsorbed from the blood. Other pathways by which sodium can be reabsorbed is passive diffusion and osmosis. Other mechanism is the most important sodium-potassium ATPase. This is the luminal membrane. The brush borders in the luminal membrane increase the absorption by 20 times. The sodium is being taken from this luminal membrane and is being effluxed from sodium potassium ATPase and backly reabsorbed into the blood. This maintains the negative intracellular and decrease a negative charge into the intracellular compartment. After the reabsorption through osmosis, transcellular pathway, and from luminal membrane, the most important hormone that is being maintaining the sodium is vasopressin, which is being secreted from the posterior pituitary. The stimulation for release of vasopressin may be hyperosmolarity, hypovolemia, and hypotension, which possess the release of vasopressin acting mainly via V2 receptors into the renal tubules. This absorbs this maintains the collecting tubule renal loop of Henle and increase the permeability of water reabsorption. Further, this increases the blood volume and increases the blood pressures. Talking briefly about fractional excretion of sodium, this is mainly important because this measures the percent of filtered sodium which is being excreted into the urine after tubular secretion. The formula for this is mentioned: urine sodium into serum creatinine divided upon the serum sodium and urine creatinine. This ratio is being labeled whether it is less than 2.5% or more than 2.5%. The ratio less than 2.5% indicates the prerenal disease, whereas it is intrinsic if it is more than 2.5%. But in cases of preterm babies, this FENA ratio may be normally till 5%. Why are the newborns different in handling the sodium and water? This is primary reason is because of the tubular immaturity and there is limited reabsorption and tubular secretion in cases of preterm babies. Most important other cause is the expression and immature function of sodium potassium ATPase pump in preterm babies. As we have previously mentioned in this slide, this FENA may be normal till 5% in preterm babies. We'll be dealing about various disorders which can be classified into isonatremic dehydration, hyponatremic, and hypernatremic. More emphasis will be on hyponatremic causes and management. Isonatremic dehydration is when the equivalent losses of sodium and water occurs from the compartment. This leads to isonatremic dehydration, and mostly in the preterm babies and the babies who are being nursed in NICU, this is caused due to the thoracostomy tube placed in situ, the ventriculostomy drainages that lead to equal loss of both water and sodium components. And most importantly, the renal losses that occurred in very low birth weight babies. Clinical signs may be with the percentage of dehydration, the change in vital signs like tachycardia, decreased blood pressures, delayed CFTs, decreased urine output, and metabolic acidosis. So to assess the dehydration, always a pre-illness weight and percentage of dehydration is being calculated. Every 1% of the dehydration is corresponding to about 10 ml per kg of the fluid deficit that is being needing to be replaced. And the severity of dehydration is further classified into mild, moderate, and severe, depending upon the percentage less than 5, between 5 to 10%, and more than 10%. This range can vary. Some of the textbooks quote it as more than 12%. And with further increased dehydration, the signs and tachycardia increase. There may be weak peripheral pulses, decreased BP, mucous membrane is dry, cold and motile peripheries, and altered sensorium. Now, talking about hypernatremia, the normal levels of sodium are between 135 to 145 millimoles per liter. When it is less than 135, it is labeled as hypernatremia. And further, mild, moderate, and severe hypernatremia are classified as ranging between 146 to 149. Moderate is more than 150, and any sodium levels which are more than 170 are labeled as severe hypernatremia. A study from the UK showed that approximately 7.1 to 21% of the babies, especially in primary mothers who were exclusively breastfed, had hypernatremic dehydration, especially during the summers. The etiology attributing to breastfeeding dehydration may be because of exclusively because the breastfeeding is ineffective, And if the baby's in formula feeds, the improperly mixed formula is the primary cause of hyponatremia in these babies. Other causes may be indigenous intake of high soda bicarb or high osmotic. Why is it that most of the time the term babies who are being exclusively breastfed are more prone for hyponatremic dehydration? First and foremost important cause of this is inadequate breastfeeding or inadequate latching. Second most important is maybe there is the breast milk containing more of sodium levels, which we'll see in further slides, and the formula feeding inadequate dilution leading to further hyponatremia. It is being seen that the breast milk initial phases contain higher content of sodium, ranging from 22 millimoles per liter, which further decreases as the milk matures. After 2 weeks, it decreases to about one third of the sodium content. Colostrum contains about maximum of sodium content. Apart from breast milk, other composition of body fluids, the diarrhea fluid usually contains lower sodium values ranging from 10 to 90. The average value is around 52 to 54 milliequivalents per liter. But the small intestine and ileostomy fluids contain higher sodium levels. So the babies who are on ileostomy or the drainage is being done, the replacement of the losses is exclusively important in these babies as they may lose varied amount of sodium from their drains. So this scatter plot diagram is for breast milk sodium content, which clearly depicts that the initial 4 days have higher sodium content, and as the time increases, the breast milk sodium content decreases in the breast milk. Only the sodium and chloride values decrease as the time increases in breast milk, but the other values like breast milk volume and lactose content tremendously increases with increasing time. After reviewing all the causes, now we are able to classify hyponatremia into hypovolemic, euvolemic, and hypervolemic hyponatremia. Most common amongst the term babies who are being exclusively breastfed, the commonest cause is hypovolemic hyponatremia in these babies. And in the preterm babies who are being nursed in NICU, the losses from radiant warmers, excessive diuresis due to drugs or osmotic diuresis is the another cause. Euvolemic hyponatremia is lesser encountered, but this may be due to the loss of vasopressin, be it central diabetes insipidus or nephrogenic diabetes insipidus. So this latest study published in 2017 March in Pediatric Research, this tried to aim, Spath et al. Tried to aim to look for the sodium supply, which contributed to risk of hyper and both hyponatremia in extreme preterm infants. This was the express study, which aimed to look for the data in extreme preterm babies less than 27 weeks by retrospective analysis, and then their nutritional, laboratory, and weight data were subsequently collected from the records. What the study concluded was that the sodium levels increased from 135 millimoles at birth to about 145 millimoles at the day 3 of life. Further, they determined that approximately 50% of the babies had hyponatremia in the first week of life, which gradually changed into hyponatremia in about 80% of the babies on week 2 of life. They determined that the main sodium composition which was received by the babies in first week of life was in the form of blood products or the saline injections or the boluses that babies received. But in the second week of life and third week of life, the parenteral nutrition was a major cause of hyponatremia or the sodium source. In another study published in Pediatric Research April 2020, the extreme low birth weight babies, especially less than 28 weeks, were being studied, and they were being studied to see the inadvertent sodium load over the recommended intake. Ibinster et al. Aimed to determine that the sodium load during the first 2 weeks of life and influence it on other morbidities and mortalities in extreme low birth weight babies was seen. What they found out was that the 90 babies with birth weight of 700 gram and mean gestation of 24 weeks were included. And the mean sodium intake during first 2 weeks was 10 millimoles per kg per day, whereas the daily recommended was dosed from 2 to 5 millimoles per kg. This was significantly higher in these extreme preterm babies. And every millimole of sodium which was increased during this first week had increased chances of bronchopulmonary dysplasia and higher grades of IVH in 45 and 30% of the babies. What this study concluded and what the learning point from the study was that the sodium intake in Elgin babies during first 2 weeks of life was about 2 to 3 times higher than the recommended daily allowance. And this high sodium intake was not directly related to severe hypernatremia, but was related proportionally to higher morbidities like BPD, IVH, and necrotizing enterocolitis. So this can be avoided by replacing the sodium with saline fluids and giving hypotonic fluids in cases of fluid boluses, if at all needed. The etiological factors for hypernatremic dehydration are most importantly the primary para mothers who deliver by a cesarean section and any associated breastfeeding anomalies or breast anomalies or breastfeeding issues or time to initiate first breastfeeding is being delayed. Clinical features, as wonderfully explained in the case management, may lead to poor feeding, high-pitched cry. The doughy skin is the classical sign of hypernatremic dehydration because of the late loss of fluid from intracellular compartment to extracellular, excessive body temperature, lethargy, and maybe babies who may present with seizures if at all it is severe hypernatremia. Complications involve the CNS, the kidneys, and the liver functions too. The hyponatremia, which is severe, may lead to acute renal failure, DIC. Most common are the bleedings and thrombosis that is being seen in hyponatremia and during the treatment of hyponatremia, whereas myelinosis is being seen commonly during the treatment of hyponatremia. Before managing and learning about the management and treatment of hyponatremia, let's have an overview of how much is the sodium content of the various IV fluids that we use day in and day out in ICUs. The sodium content of NS is 154 and half NS is half of the 77, 1 by 4th NS is 38. The soda bicarb that we use in preterm babies or in majority contains higher sodium values at 1000 milliequivalents per liter. It is highly osmolar to with osmolarity of 2000 milliosmoles. So after discussing the causes, etiology, and clinical features of hypernatremia, the management involves two priorities. First phase is the restoration of intravascular volume, and second phase is the dehydration phase. Whenever a baby is being in hypernatremic dehydration, our foremost aim should be to restore the IV volume by giving IV boluses at 20 ml per kg, which is isotone. But this is applying only to the sodium values which are in moderate dehydration. Any value of more than 175, we have to give isotonic fluid by making a special fluid for this. We'll learn it in subsequent slides. The first phase, restoring the intravascular volume, is giving normal saline, 20 ml per kg over 20 minutes. This normal saline can be changed to a different special fluid when it is severe hypernatremia. The fluid can be repeated again if the intravascular volume is not restored. Further, the type of hypernatremia can be managed. Acute hypernatremia with mild serum sodium levels can be managed over 24 hours, whereas the moderate to severe hypernatremia values are to be corrected slowly over 48 to 72 hours, depending upon the range of values that is being shown into this video. And the learning point, especially from the case management, is this, that mild hypernatremia can be managed with alone oral feedings and no need for IV treatment is being needed in babies. The babies who are being dehydrated and has inadequate feeding, you give them extra maintenance fluid and the serum sodium values normalize. First approach is mostly that is being commonly used is that give typical fluid dextrose 5% with half normal saline, and when the baby passes urine or no contraindication for giving KCl, 20 milliequivalents per liter of KCl is being given. This value is usually 1.2 to 1.5 times the maintenance. If the sodium values that are being targeted at around 12 to 15 milliequivalents per day, if they decrease rapidly, then idea is to either decrease the rate of IV fluid or increase the sodium concentration of IV fluid. So in cases of severe hypernatremia, the correction is over 48 to 72 hours, and in mild hypernatremia, only oral fluids, oral feeding in maintenance doses can be better in stable neonates. Discussing the maintenance fluid, there are around 4 or 5 terms that we need to calculate for severe hypernatremia babies. First is the maintenance fluid, then is the free water deficit, the amount that is being given for extra rise in sodium values. Third is the solute fluid deficit, and then we'll see how to make bolus fluid in cases of severe hypernatremia. So free water deficit in cases of moderate hypernatremia, for every extra sodium value more than 145, we multiply this by 4 ml per kg for extra rise more than 145. In cases of severe hypernatremia, this free water deficit formula changes to 3 ml per kg for extra rise. So, what is the concept of this free water that we are dealing, and we are saying that more than 175, we need to prepare a special fluid for giving isotonic boluses. Then the serum sodium values are 145 milliequivalents. Our normal saline has isotonic content as 100%, and there is no free water in this. So it remains isotonic when the sodium values are 145. But when there is severe hypernatremia, even this 0.9% saline, which was isotonic for a baby whose normal sodium value was 145, this is hypotonic for the baby who has serum sodium more than 170. So in this case, if we give normal saline to a baby in restoration phase who present with severe hypernatremia, the fall of sodium will be rapid. So we need to prepare a special fluid which is isotonic to it. Isotonic means that any value, for example, if a baby has 195 milliequivalent sodium, then we need to target only 15 milliequivalents per liter less value to stabilize. Like for this, target value will be 180. So we'll have to prepare a fluid which will clear this 180 sodium levels. We'll see how is it prepared. If it is clearly visible, please take a look at this. This is example of how to prepare a hypertonic saline for restoration phase. This was a 3 kg birth weight baby who was on exclusive breastfeeding. He came in severe dehydration with sodium levels of 185 and hemodynamic instability. So how to prepare a saline for this baby, because 0.9% saline will be too hypotonic for this baby, as we have seen that the value is 185. So we need to prepare a special fluid. How to prepare it? Ideal fluid that we need to given is 185 minus 115, that is 170 milliequivalents. So how much amount of hypotonic saline is being added to normal saline that this concentration of sodium fluid is achieved. So it is achieved in per liters, 1000 ml into the desired sodium composition and the saline composition, that is 154. This is further divided by 513. This 513 is because 3% saline contains this much sodium minus desired 170 milliequivalents. This amount after calculation came as 47 ml. So in the baby who's 3 kg, if we are giving 20 ml per kg of bolus in 60 ml, in 60 ml bolus, how much hypertonic saline is being given is this much. So in 1 liter of fluid, if we give this 2.8 ml of hypertonic saline, this fluid will be given as restoration fluid in severe hypernatremia. Giving alone saline will cause rapid decrease in sodium, hence this is not done. We'll see in next slides also, if at all it is not understandable. So clearly we'll see with the example. This was a day 8 of life newborn with birth weight of 3 kg, brought with severe dehydration and present weight of 2.4 kg. So expected dehydration was 20% weight loss in this baby, and sodium values was 170 milligrams. So how to calculate all the deficits that we have been talking about? Total fluid deficit will be 10 ml per percentage. Birth weight was 3 kg in this baby, and percentage of dehydration was 20%. So it comes out as 600 ml. Then on day 8, if we are about to give maintenance fluid to this baby, is 150 ml per kg. So this comes out as 450 ml. What is the free water deficit is that in moderate dehydration, we have seen that 4 ml per kg of the desired concentration of sodium is the free water deficit that we need to give extra to this baby. So this is 4 into 3 and desired, this is present sodium value 170 and what we desire is 150. So this comes out 240 ml. Next term is solute fluid deficit, commonly known as SFD. This is being calculated from subtracting the free water deficit from total deficit. So total which was about to be given was this 600 ml and minus the free water deficit is 240 ml. So this is 360 ml. We'll chalk down all these formulas and then we'll further see how these are being added and subsequently subtracted for the maintenance fluid over 24 hours. After seeing all the deficits, now we need to find out what is the solute sodium deficit for this baby. So in solute water deficit in liters is 0.36%. This can be taken as 0.4 also in severe hyponatremia. Total body water is about 0.7 or 70%. So we take it as 0.7 into normal sodium levels 135. So this is the amount of sodium that is being deficient in this baby and we need to replace the sodium apart from the maintenance sodium that are being needed daily. So this is 4 Me2 per kg 12. So the sodium which we want to give is this 39 plus 12 to replenish the deficits in maintenance sodium values for this baby over next 24 hours. So we calculated all the deficits. So how to give this fluid? First 24 hours, half of free water has to be given. Just take a remind in how much free water was there. 240 ml was about free water. So half of this free water is being given in first 24 hours and other half is being given in next 24 hours. Because this is moderate dehydration, so we need to correct it over 48 hours. So 120 is the water. The solute replacement came out to be 360 ml and maintenance at 150 ml per kg was 450. So all this combined together is the amount of fluid that we need to give to this baby over first 24 hours. And the sodium which we need to give to this baby, as we have seen, this was a solute sodium deficit 39 and this was the maintenance sodium levels 4 Me2 per kg 12. So 51 Me2 of sodium is being given to this baby. Further, in next 24 hours, only the maintenance and half of free water is to be given, and only the maintenance sodium is to be given. So, primary thing is to look for first 24 hours fluid and deficit corrections, be in the form of sodium and extra fluid in the form of solute replacement. This fluid will be ordered as out of 930. The amount of sodium that you need to give in 5% dextrose is normal saline also. So if we want to give 51 ml of normal saline, so 930 minus, this comes out around 330 ml. So 330 ml of normal saline with remaining 600 ml of dextrose 5% is the fluid that we have to give at the rate of 38 ml per hour in first 24 hours to this baby. But most of the times, this corrections usually over correct the sodium levels and we end up taking 1.5 times the fluid volume as a relaxation and most convenient method of correcting hypernatremia. After all these mathematical calculations, we need to monitor the electrolytes very frequently, 4 to 6 hourly. Renal function tests are to be measured daily. Weight monitoring 12 hourly to assess the deficit correction, under correction or over correction, and monitoring for therapeutic edema and signs for it. It is at all found that it is very rare to have peritoneal dialysis in hypernatremia. Most of the time, the fluid therapy is sufficient for correction. As we know that the myelinosis is most common in hyponatremia, whereas too rapid rate of dehydration may cause edema and formation of idiogenic osmole in the brain, which further leads to shrinkage of brain cells and bleeding and hemorrhages in the baby if we are overcorrecting. At any point of time, if the baby develops seizures, we need to give 3% saline, 4 ml per kg in 4 to 6 hours. This usually resolves the acute symptoms, and then the fluid that we have calculated is being given. Kamrani et al., when reviewed the babies in 1 year follow-up, they found out that there was a delay at 6 months in about 25% of the babies who had hypernatremia in neonatal period. And this delay was about 12% in babies till 2 years of age follow-up. After discussion of fluid calculation, causes, and management, how can we prevent hyponatremia, especially the breastfeeding dehydration? It's basically from the history, maternal history. The latch score is important because most of the times when the babies are exclusively breastfed, uh, there's hardly any milk and the baby is being dehydrated and comes in severe dehydration. So maternal counseling, the latch score, positioning and attachment of the baby is important. How much stool output, how much urine output frequency and duration is further assessed in history. And the clinical examination involves the assessment of genitalia as being beautifully covered in the case presentation to look for other errors which are causing this electrolyte imbalance. The term babies usually have maximum weight loss of around 10% in first 3 to 4 days, but they regain their birth weight by first week of life. Whereas this weight loss is excessive in preterm babies and they regain their birth weight till maximum of 2 weeks of life. So in these babies who are being treated for hyponatremia and are being discharged, what follow-up is important for them is first and foremost is adequate lactation counseling for the mother regarding adequate breastfeeding, composition, monitoring of urine output by the mother, anthropometry monitoring, especially the head growth in subsequent follow-ups. If at all the baby had developed any brain hemorrhage or sinus venous thrombosis, then serial brain imaging during the follow-up is needed as and when required. Developmental assessment if the baby is going well, and danger signs counseling for the mother at home also is important. Apart from this, the development supportive care, the vision and hearing follow-up is too. So a brief point on hyponatremic disorders. This is when the sodium values are less than 130, may present with apnea, seizures, and hypotonia in cases of severe hyponatremia. So this is further classified into euvolemic, hypovolemic, and hypervolemic hyponatremia. Most important to evaluate hyponatremia is rule out pseudo-hyponatremia because excessive lipid values and excessive protein values may also present as pseudo-hyponatremia, especially in the babies who are being treated with albumins for septic shock. Most commonly, what in preterms we get is hypovolemic hyponatremia, where both sodium and water content decreases. In all the cases of hyponatremia, if the urine sodium values are less than 20 or more than 20, we need to evaluate for the same. Most of the times in NEC babies or in the babies who have EPS and urine sodium values are less, we need to expand the fluid volume. Whereas the restriction of fluid volume is only required in cases of hypervolemic hyponatremia. So with all the mathematical calculations that are hardly to learn and very difficult to do it at bedside level when a sick baby with severe hyponatremia is there. So we have this app, Neonate AI app. This app gives calculation of the fluid, solute fluid deficit also, how much amount of 3% saline to be added in the fluid for boluses. This calculator gives it all just by giving the birth weight of the baby, how much maintenance fluid you want to give, and the admission sodium values. So this is the calculator. It has got other charts also. So in this calculator, if we plot this birth weight, sodium values, and maintenance, then it gives this information. This is the emergency saline volume that we want to give. Like in this, I have put 3 kg birth weight with 170 sodium and 150 ml per kg maintenance fluid. So this is the restoration phase, and the correction phase is this: 13% water dehydration, and how much water free water deficit is 185 ml. Maintenance load was 448 ml, and the total is this. So this calculator can be used in phones also, and is very easy and convenient to use. No need to learn those difficult calculations if at all you are finding it. Take home messages from all this case presentation and session on hyponatremia is that the dysnatremia's treatment is always and always represented by the slow correction of electrolytes. Mild to moderate hyponatremias in hemodynamically stable babies can be corrected alone with the oral feedings, where no need of IV fluid is being given. In cases of acute forms in hyponatremia, when we think the risk of sequelae is usually greater than that of myelinosis, then rapid correction has to be given. But this rapid correction is not wholesale for chronic hyponatremia or chronic hyponatremia. After management, treatment, frequent sodium monitoring and renal function test is important. And the relationship between sodium levels and diuresis must be monitored frequently. These are my references. Thank you all for your patient listening. Questions and comments.